Welcome back to the second part of our program, Ensuring Holistic Continuity of Care in Women's Health. I apologize, I failed to introduce myself. I am Beth Allen. I know many of you, but I am the Nurse Practitioner Director, and we just wanted to remind you that you can call, please call and email us during the broadcast. We do have some questions we're going to talk about in just a second after we discuss our CEU packet. Also, the handouts, the sign-in sheet, the evaluation are all available online where you registered, and you will need to register for this program in order to access those materials. Continuing education credits have been approved for nurses and social workers for today's program, but they are only available for our current ADPH employees. In order to receive credit for this training, you must watch the entire program and then complete and return the sign-in sheet and evaluation. While content may continue to be relevant, continuing education will only be awarded for 1 month for nurses and social workers expiring on September 1, 2017. We really want to encourage everyone to go ahead and get this in service under their belt so that you can move forward with patient care. I would like to also take a moment to thank Ms. Valerie Cochran, who helped us with the continuing education packet and has been involved in this process. So now we will go to some of the questions that we have had. After that, we will go on with our program, but this is a good time. If you want to go ahead and call us, please do so. We may have missed a call. You can call now, and we're going to go ahead and go through some of the questions that relate to our first half.
Good morning. One of the first questions we have is that the updated form that is used for problem and deferred visits, the question is, will we use this for supply visits? And that is no. That form is used for the problem visits and when they come back in for their 6 months deferral after they've had their initial history done. So that is not for supply visits.
And you will continue to use the stamp for your supply visits, just to reiterate.
Another question we have is, do we still use the PT+3 for the deferred physicals and the deferred visits? And that is, yes, that is still on that back sheet, the 12, page 3. That is still there, and also, like Beth just said, on the stamp, we'll still use the stamp for the PT+3. Another concern is that there isn't a place, or there's not enough room for possibly the last 3 abnormal pap smears, and where we'll write that and how that'll be handled. And there's a small section that addresses abnormal pap smears, but then on the back sheet, that third sheet, there's a lot of room for the nurse practitioner to make notes and to get more clarification of any abnormal paps and when they were and what they were.
And if I can just comment on room to write about the abnormal pap smear and the patient's pap smear history. You know, in an attempt to make this the self-history form, I guess, user-friendly, one of the many complaints that we got initially was it was too wordy and it looked crowded. So, and clearly, you know, we took all of this into consideration when tweaking the form. So something had to give, you know, in trying to massage it a bit. So the history, in elaborating on the history, the registered nurse can do that. And truly, the nurse practitioner is going to be delving into the history of the patient's abnormal pap smears. So that's something I think that can, you know, working together, the nurse and the nurse practitioner can figure that out. So that's sort of how that portion will play out.
Another concern is, will the forms be available in Spanish? And that answer is no. You know, we'll use the language line to complete the questionnaire like we're doing basically now. And another question was, what if the patient has no medical home and is not being followed? And I guess that's asking about their medical history if they have problems. So if they need referrals, we'll still make referrals just like we're doing currently. The next question is, when does this form start and when does the protocol take effect? The protocol is available currently, and the self-history form is on the document library, and we do plan to start using it immediately. So it will take effect.
So yeah, if I can just reiterate that in the document library, all the forms that we are discussing today, the self-history, the update, the PAP notes, and the breast notes follow-up forms are in the CHR manual, the first four forms you see. Of course, they're in our packet as well. We can use those immediately. This has been under review for quite some time. We promise we didn't just dream this up yesterday and give it to you today. We have been working on this, but again, it's a work in progress, and that's why we want your input so much. As far as the protocol goes, it is forthcoming and will soon be available as it goes out. Just wanted to sort of reiterate that. Any other questions?
Looks like that's the questions for now.
Okay, so we have a call from Tuscaloosa County. Caller, you're on.
Yes. My question was on page 9 of Krista Hood's information about the migraines with the aura. On the first slide on page 9, when it says aura, like on the previous pages it talked about how vomiting was not an aura, the nausea wasn't an aura. Then you put at the title of this page aura, and then it had all the stuff that was listed that wasn't aura, and we've always known not to be an aura. So it's almost a little contradictory, so I was just trying to figure out what were we really saying there.
Oh, the one that has all the hodgepodge of symptoms?
Yes.
Okay. Those don't specifically relate to aura or non-aura. They're headache symptoms. Correct me if I'm wrong.
Yes. Thanks for calling, Latoya.
We're going to give Krista the mic just a sec.
Okay. Okay. The way the slides were broken down, on page 27 of your protocol, we listed migraines without aura as symptoms that they could explain as nausea, vomiting, sensitivity to light, sound, visual blurring, spots, flashing, and pains that make the movements that make the pain worse. So that all goes under migraines without aura. And then migraines with aura are the numbness, pins and needle sensations, the weakness, the visual disturbances, the tingling, difficulty speaking, and the odors. I think the way the slides were broken down, it split them. Does that make sense now?
Well, I understood about what was aura and what wasn't aura. But then on this slide in particular, when you put at the top of the aura, it's almost as if what you just said. Does that make sense? Maybe it would have been better if the title could have been symptoms of migraines, not necessarily aura. Because if you put aura at the top, it would almost, if that's the first thing you picked up and you didn't read the previous slides, it would lead you to believe that this could possibly be aura.
It's if I can just say, am I good? Yeah, Latoya, if I can just say, it's just a slide that gives you all the type symptoms. It's just a slide that gives you all of the symptoms. It's not titled aura, although that's the first thing at the top of that slide. That's not the title of the actual slide. Sorry for any confusion.
Okay, and can I ask another question?
Sure, of course.
Now, on the self-history, you know how we were discussing that the nurse would review and make sure all the questions were answered? So if the patient has not answered all the questions, do we give it back to them so they can answer them?
Well,
it's,
of course, this is going to be a learning curve, right, for them as well as us. So, yeah, I mean, if we expect them to continue to do this, they've got to be taught how to do it properly. So I guess the short answer is yes. I know the devil's in the details, but you know, that's why we want your feedback as you use these with the patients. What's working, what's not working, and we will see trends statewide from that. So thank you.
Okay, yeah, that was my question, because I was like, I guess if we reviewing it, can we just go ahead and write whatever in, or do we have to give it back?
You don't answer the questions for them, no.
Okay.
That's their portion.
Okay, thank you.
Yes, thank you. Okay, we have a phone call from Hale County. Caller, you're on.
Hi, this is Kathy from Hale County.
Hey, Kathy.
Hi there. The nurse practitioner usually gives us a list of who's on call. And when Dr. Thomas or whoever is in model clinic, does the nurse still call if we don't have a nurse practitioner available? Or do we try to reach the nurse practitioner first?
No, I mean, it's set up for the transition. I'll let Dr. Thomas or Dr. Maxwell expound, but it's set up for the nurse to call the physician, just like the nurse practitioner would call the physician. And I'll let Dr. Thomas continue.
Hey, Kathy, thanks for your question. When I'm in the model clinic, I still take phone calls, and on that email that goes out on a weekly basis, you will see that there are instructions to call the Montgomery County Health Department, because the reception is not always the best while I'm in a model clinic. So there is a number, I think it's 293-6400, which is the Montgomery County Health Department number, and of course area code 334, and ask for the family planning clinic to be put through to the family planning clinic. And that's where I can be reached while I'm in clinic.
Okay, thank you.
That number, Kathy, is listed on the call schedule when we have model clinic.
Yes.
Okay, great.
All right, thank you.
Thank you so much.
Bye.
Bye.
I just want to reiterate for those clinics that are involved in the upcoming Title X visit, Etowah and Otago County specifically. I think one of the questions, via email asked whether the annual patient self-history is going to be implemented. And I think since this is kind of a very this visit is a anxiety-producing visit, and I think for those two counties, Otago and Etowah, I think you should continue business as usual, using the old form for that day if that is going to make things easier for you and not create any angst. I think everybody else should go to using the form as soon as possible or immediately.
Do we have any other email?
We do have one more email, and it's regarding, are these forms available on Falcon or just the document library? And right now, they are on the document library.
And Falcon will soon be going away, just to add to that. We looked at the Falcon process, but it is, of course, everything that we're doing is a bridge to the EHR. So Falcon is soon to be no more, and I hope that answers your question, but if it doesn't, just call us. But all the forms are available on the document library in the CHR manual section. The first 4 forms you can select. Okay, we have a call from Marshall County. Caller, you're on.
Yes, we were wondering, we had some questions about the tables, the different, for example, like with migraines with Aura on page 11, under POP, it's got a 1 with a check, but you can only dispense 6 months. It's like that through a few tables throughout, and we were just wondering why the dispensing number would not be a 2 instead of a 1.
You want to answer that? Okay.
Okay. We use, as I said, we use the US MEC's framework when we develop the tables. So MEC says, you said migraines without aura. US MEC says migraines without aura is a 1. We did not go and change the numbers based on what we wanted them to be. We just added the consult and the comment sections. So even though the migraines with aura for POPs is a 1, we don't feel like that's really a 1. So,
okay.
So these are global recommendations. So in other parts of the world, we do not want women to get pregnant. So they may see this a little differently than the health department systems see this. But for our intents and purposes, we didn't want to give it, okay, it's a 1. Really, we feel more like it's a 3. So we didn't change the numbers. We did put the dashes in sometimes where we thought, well, that was a number 3. And we felt like, no, we just don't want to use that method at all for that condition. So the dashes were what we did, but we did it for that purpose. So if it said a 1 or a 2, I think breast cancer was one of those, and it listed like a low numeric number, like a 1 or a 2. Well, we were not going to give a hormonal method to a patient that had breast cancer, so we made those all dashes. So we wouldn't cause confusion that way. So that's why that happened.
Okay, I have a few more questions, if that's okay.
Okay, yeah.
Okay, on thyroid cancer, does that mean current or history, or both?
Say that one more time.
On thyroid cancer, does that mean if they have a current, if they currently have thyroid cancer, or if they've had a history?
It could be current or it could be history. Because in the disclaimer, we also listed if you had a history, and then within the past 5 years. So anybody that we're dealing with that has a history of cancer, we definitely want to consult on that.
Okay. And do we still DC a method if they have an onset of migraines after starting the method? Is that still in this protocol?
When we're withholding the method, like if we're not changing, say they were on a combined method and they started to have migraines, that would be a good, our whole goal is to provide methods. So that might be a good chance to, before you discontinue, you may change the method to something else. You could do a consult to kind of talk through it with the collaborating physician to see if they had any further guidance, and see if there's any additional history we could get before we completely eliminate hormonal birth control.
Okay, and I have one more question.
Yes, Dr. Talk, hold on just one second.
Yes.
Just to add to that question, if your patient is on a hormonal method, if I'm understanding the question correctly, and migraines, they start to have migraines, that's usually not a good sign. So that's something that would be, or a case scenario that we would need to discuss further. And definitely consider discontinuing the hormonal contraception, since that may be a trigger of the migraines. You had another question?
Yeah, thank you. Yes, I have one more question. We are 50% Hispanic patients, so on the self-history form, I know you had said use the language line, or the interpreters. Can the interpreters, do they need to help them fill it out, or can the nurse just ask the questions and fill it out for them? Because a lot of our patients speak dialect or are not able to read. So what do you suggest? That can the nurse just ask the question?
I would say make your life easy, and whichever way works, as long as you are comfortable with the interpreter in that process, it could be done either way.
Okay, great. Thank you so much.
Those are great questions. Thank you very much.
There is one more. Somebody emailed that the breast follow-up sheet will not print. It says it's out of margins. So is that something that...
Work through it.
Yeah. We'll definitely work through that and look at those and get that corrected. Thank you. Okay, so that's all of our questions at this time. We do need to get into the second portion, which we will continue the patient self-history, and then we'll go into our follow-up aspect. I am glad to introduce Ms. Nasa Hernandez, Nurse Practitioner Senior, who will complete the patient self-history portion, and Ms. Deborah Davis, Nurse Practitioner Senior, who will then talk to us about our follow-up process changes. Nasa?
Thank you, Beth. I will be reviewing the self-history form with you guys, and before I begin, I want to let you know that I am aware that a lot of this information is common knowledge, and you are very, very familiar with this, okay? But it was my intent to make this beneficial to the new nurses and new nurse practitioners as well. So we're going to be looking at this form from a nurse's point of view, because the nurse will be the person reviewing this form with the patient, okay? Okay, why do we take a medical history from the patient? And why do we ask the things that we ask when we're collecting a medical history? Two things. Number one, a good medical history will allow us to deliver good quality care. And also because, as we know, some medical conditions will affect the selection of birth control method. So we need to know exactly what is going on, medically speaking, with this patient, okay? Now, even though the medical history taking is the first step, it goes a long way toward providing you with a lot of information that you can use to develop a plan of care that will meet each patient's specific needs. So make the most out of your encounter with the patient, okay? Get as much information as you can. Like I mentioned, some medical conditions will affect the birth control selection method. So I'm gonna go through some of those, and I know Krista already talked about some, so I'm just gonna lightly touch on them, okay? Let's take a look at hypertension, for example. You have a patient that comes in, and she's requesting a combined method. Blood pressure on this visit is 140/90. So we all know that blood pressure needs to be less than 140/90 to provide a combined method. On recheck, because we're going to recheck 5 minutes later, it's going to be like 140/94. Okay, so it went up a little bit more. So if you give this patient an estrogen-containing method, blood pressure can go even higher, okay? So it's not safe. When we give estrogen, blood pressure can go up to 6 millimeters of mercury on the systolic and up to 4 on the diastolic. So this 140/94 can turn into a 146/98. 146/98, I'm sorry. So why do this when there are safer methods, okay? Now remember, patients cannot always get what they want. But it's important that you tell them the reason behind it. Tell them why they cannot get what they're asking for, okay? At the end of the day, remember this. It's not what you say, but how you say it, how you tell this to the patient, okay? And knowledge is power. When we educate our patients, we are giving them the ability to make better decisions. And most likely, this patient will be more compliant with the chosen method. Okay, so take the time and just go a little bit further and explain. Tell them the reason why. Let's look at osteopenia and osteoporosis, okay? This is another example. We know that DEPO is associated with the decrease in bone mass density. Back in 2004, the FDA added a black box warning to the DEPO saying that the loss of bone density that prolonged use of the DEPO shot may result in the loss of bone density. And we know that the loss of bone density weakens the bones and it's going to increase the risk of fractures. In 2005, the WHO concluded that there should be no restriction on the use of DEPO, including no restriction in the duration of use. So we will continue with the current recommendation not to stop the DEPO after 2 years. Okay, and we need to recommend, of course, counsel the patient on the use of daily calcium and vitamin D. You do not have to send the patient for a DEXA scan if the patient has been on DEPO for the last 10 years, okay, unless the patient is at high risk for osteoporosis. If this patient is on chronic steroid use or this patient has a strong family history of osteoporosis, then this is a different story. They may benefit from the DEXA scan. I also want you to keep in mind that some medication for osteoporosis can be teratogenic, so it is important that the patient is on a reliable method of birth control. And this is why it's so important when you're reviewing the medical history and the medications that the patients are taking, ask what they're taking this for. Sometimes they list 1, 2, or 3 medications, and when you look at the medical history, they don't mark anything. So find out, why are they taking this medication? What is it for, and who is prescribing this medication? Okay? So it is important that you just ask a little bit more. This right here tells you what's the recommended daily intake for calcium and vitamin D. From 9 years to 70 years, 600 units of vitamin D is what they need every day. And after 70, it goes up to 800. For calcium, 9 to 18 years, 1,300. From 19 to 50, goes down to 1,000. 51 and on, it goes to 1,200 milligrams of calcium a day. So these are the current recommendations. Migraine headaches. Krista already talked about this, so I'm just going to touch very lightly. The most important thing for you to remember is if a patient lists migraine headaches, you have to determine if they have an aura or not with these headaches, okay? We know that a personal history of migraine headaches, it's a risk factor for stroke, and the presence of an aura further increase this risk. Now, the things that we're more concerned about are the focal neurological symptoms such as scotoma, such as a blind spot, zigzag lines on the peripheral vision, any numbness, tingling, or difficulty speaking. So when you are reviewing the history, ask the patient something like, does anything happen to you before you get a headache that you know you're about to get a headache? Some people will tell you, well, yes, I smell blood before I get a headache, and then it hits me. Well, you know that's an aura, okay? So if anything like this happens before the headache, that is a migraine with aura. In the protocol, like Krista mentioned, we have a whole section that talks about migraines with and without aura, and that is found in Appendix H, okay? And we already know that a combined method increases the risk of vascular disease, such as stroke, and this is a 3-fold increase. And if the woman is using a combined method and has another risk factor such as obesity, hypertension, and migraine with aura, the risk is even higher. So remember this, any migraines with aura, regardless of how old the patient is, you do not give a combined method. Blood clots or DVT. In the medical history, this is listed as blood clots or DVT. In the protocol section, it only says DVT/PE, but I'm looking at the medical history. But when you look at the protocol, it's going to be a little bit different, okay? Now, according to the FDA, the blood clot risk among women who are healthy, not pregnant, and are not using a combined method is 1 to 5 women out of 10,000. Now, you get the same healthy woman and you put her on combined hormonal contraception, the risk increases to 3 to 9 out of 10,000. Now, this same healthy woman becomes pregnant. Now, the risk is 5 to 20 out of 10,000, and immediately after having a baby, within the first 21 days postpartum, that risk is 40 to 65 out of 10,000 women. So we also know that several conditions will increase the risk for blood clots, such as females older than 35, smoker, history of DVT or PE, or like I just mentioned, 21 days postpartum. Now, sometimes the patient will mark blood clots on the medical history. So just don't leave it there. Ask about it, because sometimes they will tell you, yes, I do have blood clots when I have my period. Well, that's not what we're looking for. But explain to the patient what it is that we need. Or maybe they had a hematoma in the past and they think, oh, that was a blood clot. So just ask about it, and if they still say, no, yes, I did have a blood clot, well, did they put you on any medication? Did you have to take any blood thinners for a certain period of time, okay? So try to find out to the best of your ability if this patient had a blood clot or not. Seizures. In the protocol, this is listed as epilepsy/seizures. A patient tells you that she has a history of seizures. Is she on medication? And Krista already talked a little bit about this. You know, we know that the main mechanism of action, or the way hormonal contraception works, is it suppresses ovulation. Well, certain medications may alter this, okay, may decrease the effectiveness of the birth control method, increasing the risk of pregnancy. So it is important that if you see that the patient is on anti-seizure medication, that you explain the risk involved with it, and they need to use a backup method, such as condoms. We have a list in the protocol as well with this type of medication that will affect the effectiveness of the birth control method. Now, an exception here would be Lamictal. If the patient is taking Lamictal for seizures and no other anti-seizure medication, the hormonal contraceptive, the combined pills may decrease the efficacy of the Lamictal. So this patient may have to let the doctor know so they can adjust the dose of the Lamictal or add another anti-seizure medication, because if it's taken with another anti-seizure medication, then it is good. It will not affect the effectiveness of the birth control method. Now, patients with seizures, we know that the depot is the method of choice for these patients, okay? First of all, because the seizure medication does not affect the efficacy of the depot. And second, because the depot produces a somnolent effect that can decrease seizure activity. Let's talk about sickle cell disease. And in the protocol, sickle cell disease is listed under anemia. We know that pregnancies in patients with sickle cell disease are associated with a very high risk of complication. So it is important that these type of patients are on a safe and reliable method of contraception to prevent a pregnancy. The first choice for women with sickle cell disease is the depot. In addition to be a very highly effective reversible contraceptive, the depot also may decrease the amount of painful sickling crisis that happens to these patients with sickle cell disease. The use of a combined hormonal contraceptive method on patients with sickle cell disease is still a little bit controversial because of the risk of thromboembolic complications. In our protocol, it is a 2 with a star, which means you need to call and consult about a combined method. After the medical history, it comes the family history, okay? It is important that we know the family history because it can help us identify people with a higher than usual risk of having common disorders such as heart disease, diabetes, high blood pressure, strokes, and some types of cancer. Now, the types of cancers that we're concerned about are breast, colon, ovarian, uterine, and prostate. It is important that you look at this. I mean, when you look at the family medical history, look at patterns, look at genetic mutations. If you have a patient that has a history of Lynch syndrome in the family, for example, that increases the risk for colon cancer. So knowing this will help you counsel these patients in the available screening test, okay? And so they can do this as early as possible. And also it will help the patient adopt a healthier lifestyle to reduce the risk of diseases that run in the families, okay? At the end of the day, it runs in the family. You may end up with it, but at least knowing this will help you make better choices and healthier choices. Let's take a look at the gynecological history, the menstrual history. Menstrual history is like the vital signs for women's health. It gives us a sense of what's going on, and it will determine the health and well-being of the woman. So it is important for us to know when was the last menstrual history and know what the menstrual pattern is for this patient. As a clinician, we need to have an understanding of the patient's menstrual pattern. You need to be able to tell what's normal versus abnormal, what's regular versus irregular. And the only way you know these answers is asking the patient. Just as an abnormal blood pressure, heart rate, or respiratory rate may be key to diagnosing potentially serious health conditions, identification of an abnormal menstrual pattern, especially in the adolescents, may improve early identification of potential health concerns for adulthood. Now, what's a menstrual cycle? When we say menstrual cycle, that goes from the first day of menstrual period to the first day of the next menstrual period. Usually, when an average cycle is anywhere between 28 and 32 days, but it can be shorter or longer. It can go between 21 and 45 days. Anything that falls outside of these parameters needs to be evaluated. You need to investigate a little bit more. So when you're reviewing the last menstrual period, you can ask the patients, how many days did it last? Was it regular? If yes, what's regular for you. Okay, tell me a little bit more about it. You can get a lot of information out of just 1 or 2 questions. Another example, if you have a patient that tells you that the last menstrual period was 6 or 7 months ago, so then you need to ask, do you have a period every month? Is this the longest you've been without a period? Okay, you need to know what's the menstrual pattern, at least within the last year. And these are things that you need to know, especially if you're going to call to consult, okay? We need to know these. And the only way to know is just asking. So try to get the best picture that you can of the menstrual pattern. And that's what the comments section is for. You find out, the patient tells you, I've been having periods that last 21 days. Write it on the comment section. That way, the nurse practitioner can investigate a little bit more. Right here, it tells you just average menarche, usually around when patient is 12 years old. The cycle interval usually is an average of 32 days. Menstrual cycle interval is typically 21 to 45, and the flow length usually is 7 days or less. And menstrual products, sometimes you can go by that, and 3 to 6 pads or tampons per day, it's an average. And remember, menstrual abnormalities may point to other conditions. Now, you have to learn it first, so you can teach it later, okay? You have to know what you are talking about, so you can properly educate your patients and those that come after you, like new nurses, okay? Gynecological history and pap smear. In this section, ask about the pap. Have you ever had an abnormal pap? If yes, when was it? Did they do any procedures after that? And write it in the comment section. You may have a long history of abnormal paps. Write it on the comment section if you think it's relevant. Deborah will cover pap follow-up, and she will expand a little bit more on this section, okay? Did the patient have any treatment? We need to know things like these, because sometimes if the patient had a colposcopy 3 or 4 months ago, are you going to do a pap smear on today's visit, okay? So you need to know these things. Obstetrical history. Why is it important? And this form, the questions are very, very straight to the point, and they're very easy to understand by the patients, okay? So how many times have you been pregnant? How many of those were full term? How many of those were premature birth? Now, we need to know these things. A preterm delivery is a risk factor for subsequent preterm birth. So the women need to know this, that the risk is even higher because they need to begin prenatal care as early as possible with any future pregnancies. Did they have a tubal pregnancy or an ectopic pregnancy? This also increases the risk for more ectopic pregnancies later on. So let the woman know this, because if all of a sudden she develops severe low abdominal pain, she needs to know to seek immediate care. She may be having another tubal pregnancy. Miscarriages. Sometimes they write down, I've had 5 miscarriages, and end of the story. But we need to know what happened. Why? Did the doctor do any test? Did they tell you why you were not able to carry these pregnancies to term, okay? There's certain medical conditions like thromboembolic disorders that increase the risk of miscarriage. And these are things that you need to know, because if a patient had 5 miscarriages and they told her there is a thromboembolic disorder, you don't need to give this patient an estrogen-containing method, okay? So you need to know. Did they have any problems with the pregnancy? She had 5 C-sections. Why? What happened? Sometimes they have the first one because of complications, and then any other deliveries they do, it's by choice to have a C-section. But ask why. What happened during the pregnancy? The sexual history section. This can be a very sensitive subject, but the nurse has to be able to ask these questions, and she needs to be comfortable when doing so. Some patients may not be comfortable talking about sexual practices, sexual preferences, or sexual partners, okay? The best thing you can do is just try to put the patient at ease, remind them that you're asking these questions because these will provide you with information that will help you provide better care. And also remind them that all the responses will be strictly confidential, okay? And that will help them open up and just talk about it. A brief sexual history will help you identify individuals at high risk for STIs. It will also give you an opportunity to counsel your patients on how to make healthy decisions about their sexual activities. Now, always remember, you have to tailor your questions according to your patient's age and history. If you have a 15-year-old that she lists 20 sexual partners in her lifetime, well, that's a lot for a 15-year-old. So ask about it. Maybe this patient is being forced to have sex. Maybe she's getting paid to have sex, or maybe some sex trafficking is involved. So just ask them, okay? Now, sometimes they may not give you a lot of information, and they are not going to volunteer this information, so you really need to ask them about it. Also, when you ask a patient, are you sexually active? No, I'm not. Well, don't leave it there. Ask, have you ever been sexually active? Because maybe they're not at the time, but yes, they have been sexually active in the past, okay? And remember, when you're doing this and when you're asking all these questions, try to be non-judgmental and supportive. Social history. The personal and social history is the part of the interview where we learn about the patient's life, including health behaviors and personal choices. The basic social history consists of asking patients about past and present use of tobacco, alcohol, or any illegal substances. Now, why do we ask this? I know many of these questions can be very personal, and maybe the patient might be reluctant to share this type of information, either for embarrassment or fear to being judged, okay? But you should ask, again, these questions with sensitivity and respect. Now, you need to be very direct. When you ask the patients, they need to realize that this is important regarding to the care, okay? And let them know why you're asking these questions. The choices that they make today can impact the outcome of future pregnancies, okay? And you may be the only person that this patient comes in contact with, okay? So it is important that you provide the counseling. They may not be listening to what you're saying, but that's beside the point, okay? Just provide as much information as you can. Contraceptive history. Each visit with a female patient should include a discussion of her contraception needs. You need to ask what method of birth control is she using. If she says nothing, well, okay. So that opens the door for you to counsel this patient on available methods and the things that she can use, okay? So you have to ask. If the patient tells you she had a hysterectomy, ask her, why did you have a hysterectomy? Was it because of heavy bleeding? Was it because of cervical cancer or precancerous cells? Okay, we need to know. That will make a difference in knowing how frequently we're going to screen this specific patient and how frequently we're going to do pap smears on her if we have to do a pap smear. Tubal ligation, that's an option for birth control. If this patient has had as many kids as she wants to have, let them know that tubal ligation is an option. It's a permanent method, but it's also available. Now, make sure that you educate your patients, okay? General counseling and education principles can be applied when discussing contraception. The counseling process is ongoing. It never ends. So make sure that each visit you assess the patient needs, you educate them on risk and benefits of the contraceptive methods, educate them on proper use, and educate them on what to expect from the chosen method. And one thing I want you to remember is after you review this medical history, you have to sign this form, okay? So it's your signature there, it's your name, so that means that you are responsible of making sure that this information is as accurate as possible, okay? So that's all I have for you guys. I will leave you now with Ms. Deborah Davis.
Good morning. I'm going to talk a little bit about the ADPH abnormal pap and breast follow-up protocol and management. There are some new changes to these, so we're going to go through each one. I did want to list the faculty that was involved in the program today and the phone numbers. It's very important if you have any questions regarding the forms or the protocol that we talk about today that you contact your nurse practitioner seniors, or if it's a consult with Dr. Grace Thomas or Dr. Dina Maxwell. Also, if you have any additional questions regarding PAP, you could, or the self-history form, you could contact Ms. Luzenia Lawson or Beth Allen. So, we want to be able to provide the highest quality care for our patients, and in order to do that, we need to follow a protocol that's evidence-based and it has good research. It's been researched very well. And so we want you to have a full understanding of how the follow-up process works, and that all of this information that we're giving you has our patient in mind, and it is evidence-based. So in this program, we're going to discuss the ADPH requirements, which include the 6 steps used in the follow-up. We're going to demonstrate and talk about how to properly document all information that's received, such as your pap smears, your colposcopy reports, your mammogram and ultrasound reports, any pathology reports and MD notes, and the progress notes regarding the abnormal pap and breast follow-up. We'll also discuss the management priority, which includes the timelines for patient notification and obtaining information and referrals that need to be given. We're going to demonstrate that documentation by following the ADPH follow-up protocol. The framework for the ADPH follow-up protocol is the UAB post-colposcopy management guidelines. We follow the standards of care. Not just what we say this care is, but it's what the national standards are. So if a patient comes back to us following a colposcopy and they tell us that they have seen their private physician and he has told them they need a 4-month repap, we don't follow that guidelines. We follow the standards of care, and usually that's going to be to repeat the PAP or co-test in a year. So as we've developed this program, we did so because we have identified gaps or problems in care as we've done our QA. One example of this is that after a colposcopy, the patient records are not received. So I want to let you know that anytime we send the patient out for anything, we need to obtain those records. So by doing so, I want to explain what a referral is. These are actually our patients. They're health department patients. We have identified in this patient an abnormal pap for which this patient needs further evaluation. We are actually sending them out seeking guidance and possible treatment for services that we do not provide in the health department. So we have to follow up on this. They are still our health department patients, and therefore we need the recommendation for their follow-up care. And the only way we can do that is by obtaining the records. So regardless, if the patient chooses their follow-up with the health department or with the UAB or with a private physician, the next PAP and any kind of follow-up, the patient needs to be counseled on it. That appointment needs to be scheduled, and all the information needs to be documented briefly on the tickler card, and also a detailed explanation on the PAP progress notes. So we want to talk about the framework for safe practice. Basically, we want to improve our patient safety and efficacy in the care that we provide in our clinical practice. We've identified these gaps in the QA process and chart audits, and we don't want to look back at what we've done in the past. We want to move forward from today with good follow-up practices. The importance of not following the abnormal pap smears or the abnormal mammograms in some appropriate manner can result in a very serious and potentially bad outcome. Now, you may say, what can these outcomes be? Usually it could be something that could cause severe harm to the patient. It could be legal action. And let me say, when we talk about legal action, that doesn't always mean just me as the nurse practitioner or our collaborating physician. It may mean the nurse or others that's involved in that patient care. So it's important that we all work together to try to provide a safe and effective patient care in our clinical practice. And this means appropriate follow-up. So we want to go through one at a time the designated follow-up steps to help you understand what specifically should be done. Step number 1 is that we need to have the abnormal results received. They need to be date stamped. And this is new. The signature, not the initials, are required by the nurse. And you need to initiate the tickler tracking system. Additionally, there should be documentation of the abnormal result on the CHR1 and then documentation on the PAP follow-up note. So you'll have 3 areas of documentation: the CHR1, the follow-up note, whether it be the PAP follow-up note or the mammogram follow-up note, no longer the CHR10, and your tickler system, your tickler card. The reason for this is that we have noticed in the process of documentation is that these lab reports have not been received. People have been going by the fax date and time instead of being date stamped. This is a medico-legal document, and it's very important that that date stamp, the nurse's signature, and then following that, the nurse practitioner date and signature is put on the document that's been received. So I wanted you to have a view, and these are also on the document library. This is a new form that's going to go behind the PAP tab. It's always going to be on top of whatever information or forms have been received. We're going to review this form a little bit more in detail in just a few moments. I want to move to step 2. This is where the nurse practitioner should sign and date and initiate the appropriate follow-up recommendations. Now, I want to let you know that if the nurse practitioner is working in another county, it's going to be several days before she gets back. The nurse needs to read these and date and put her signature on there, and then she needs to initiate follow-up. There should not be a delay in the follow-up system. And so as soon as the nurse practitioner is in the clinic, she'll review the documents that have been received, and she'll date and sign and put her disposition for the patient. I do want you to know that all abnormals that are received need to be followed completely until they're resolved, or the patient is lost to follow-up. And if you find that there is any discrepancy or anything contrary to our normal guidelines, when you get it from the physician, then a consult with the collaborating physician may be needed. So this is just an example of some disposition notes that the nurse practitioner may write on the document. We want to move to step 3. Clearly, there are some reports that need urgent follow-up. So if the nurse practitioner is only in that county, as I said, then the nurse needs to begin immediate process of notification of the patient, the counseling, and the referral that's needed. All designated high-grade PAPs, BI-RADS 0, 4, and 5 mammograms need to be handled immediately. Additionally, there should be document notification, counseling and follow-up appointments and referral that's signed and given to the patient needs to be documented on the new PAP follow-up notes. And a copy of the referral can be faxed to the referral entity. There is a timeline that goes along with this. Any follow-up should always be initiated within a 2-week time period. Again, on designated high grades such as HCIL, ASC-H, AGUS, or CIS, seen in the follow-up protocol needs to be initiated immediately. I will say that UAB normally schedules their ASCUS or LCILs within 30 to 90 days to have that colpo. HCILs are usually scheduled within 30 days. So if you ever find that there's a problem trying to get your patient scheduled in the colpo clinic, you need to talk with your nurse practitioner. She may have to do a consult. If the PAP falls outside of our normal guidelines or the UAB colpo guidelines, they might not want to schedule the patients. The collaborating physician may have to call and discuss this with them so we can get the patient in for her colpo. I've already said that that timeline should be initiated within a 2-week period of time. As far as your PAPs go, the same goes with your mammograms. They need to be initiated, especially the BI-RADS 0, 3, 4, and 5, or any suspicious breast masses need to be initiated immediately. So if the patient has been unreachable, we need to use escalating attempts. The phone call, the first-class letter, and then the certified letter, as the protocol states, until that colposcopy appointment is made or until the patient is lost to follow-up. For instance, if the patient is lost to follow-up and if they come into the clinic for any reason, such as the DCS visit, it is medico-legally our responsibility as nurses and nurse practitioners to flip over and look at the PAP follow-up recommendation or the breast follow-up recommendation and counsel the patient. And this needs to be documented. Remember, if the patient is lost to follow-up, the chart is flagged in red on the CHR1, and so that when that patient comes in, we'll be able to look at it and flip over, see the management plan that's recommended, counsel the patient, and document your counseling. Step number 5 is that we want to assure that all appointments, follow-up appointments, are kept and that all records are received. So when a patient, I want to explain exactly what a colposcopy is. If a patient goes for a colpo, usually a biopsy is obtained, sometimes not always, and this is why the notes are needed. We also need to know if that colposcopy was adequate or if it was satisfactory, and that may not be anywhere on a path report, so we do need the MD notes, and so we have to get the reports for this. If a biopsy was done, there will be a pathology report. If a loop is done, that means that a piece of tissue has been taken, and the same for a cold knife cone, a piece of tissue is taken, so a pathology report would be needed. So now for step 6, the patient needs to be followed until the post-colposcopy or post-procedure cytology or co-test and possible endocervical curettage are completed and the patient returns to routine PAP or co-test schedule. I want to again emphasize or restate that we follow UAB post-colposcopy guidelines. These mirror the national guidelines, which are the standard of care. So let's talk about the new form. This new form will go just behind the PAP tab. It's called the PAP follow-up notes. It's always going to be on top of whatever is received. Anytime a new PAP or colpo report or path report comes in, they'll go behind this page and the flow of any received information will be added to this documentation, to this document. All PAP documentation, counseling, and notes will be made on this document. There will be no further documentation regarding Pap smears on the CHR-10. This needs to be kept up to date, and the next PAP or the next follow-up due date should be documented so that at a glance, when the nurse or nurse practitioner flips over behind that PAP tab, they're able to know just at a glance what to advise the patient about her follow-up. Now, I will say that I want to make mention of the tickler box at this point in time. We've always kept tickler cards, and you can continue to keep the tickler card. It should have a very brief note to you and should cover every step of the follow-up process and be placed in your locked tickler box behind the appropriate month for follow-up. If you prefer to make a Xerox copy of the PAP follow-up note instead of using the tickler card, you can do so. It's acceptable to use that in lieu of the tickler card. But the tickler card system is important because when that chart leaves you, you're going to need to keep track of this patient and any abnormal finding that they've had that requires follow-up. And you can't keep track without using the box, the card, or some other form of follow-up. And in this case, we do recommend the tickler card system. The document, the tickler card should just have that very brief note to you, but the PAP follow-up note will be more extensive. It's going to be in-depth as to what your attempts are, your contact, your education, your counseling, and everything. I will say that the PAP follow-up notes and the tickler card are going to segue into the new electronic health record, so in the interim we need to do the tickler card system. You're going to always document in the CHR on the PAP follow-up notes or the breast follow-up notes any intervention or counseling. What will be documented on the progress notes, the CHR-10, will be revisits, such as your depot injections utilizing the supply stamp, or problem visits. This should help eliminate some of the errors that we've had in patient care. You've always heard, if it's not written, it didn't happen. You've heard this many times as you're training as a nurse or nurse practitioner. So it's very important for you to document every step that you've done for this patient. We want to talk a little bit about what the protocol says about notification and education. We need to talk with our patient about the meaning of the abnormal finding. We want to review the recommendations for treatment and follow-up. We want to talk about a follow-up appointment, and we want to talk about the consequences of not following up on the advised recommendations for this. So let me talk about this for just a minute and define that. The patient really needs to understand the seriousness of the problem and the possibility of progression to cancer if her abnormal PAP has not been appropriately evaluated and treated. So one way that you might counsel the patient in explaining her abnormal finding, I'm going to give an example of a 20 to 21-year-old patient who has an ascus or a low-grade L-cell PAP. They have a 2-year window of time that we can watch them. And that's the reason we bring them back in 12 months and 24 months to repeat that PAP. So that gives us that 2-year window of time that we can watch them. So the L-cell may not lead to cancer, and in fact, the L-cell or the ascus can regress. It may or it may not, and so we want to watch them. If they have a high-grade lesion, this is a precursor to cancer, and it warrants evaluation as soon as possible, and that's why we would refer them. One other note I want to say in this regard is many patients don't follow up because they don't have the financial means to obtain their follow-up colposcopy. So we need to provide them with all information that is available to us, brainstorm with them or with a social worker or care coordinator about what services are available. I do know that ABCCP sends a monthly report, and we need to review that and find out if there is any information on there that is pertinent to the patients that you see, and possibility of helping these patients obtain their follow-up colposcopies or their follow-up repeat PAPs following that colposcopy. So let's talk for a second about documentation of what we've talked about with our patient. We need to put who was counseled, the patient or the guardian. We need to document how they were counseled, either by phone or a face-to-face clinic visit, the description of the abnormal finding, the treatment recommendations, the follow-up appointments, and the consequences of not following the recommendations. An example for this that you might talk with a patient, remember, is the young patient with L-cell disease. It can regress in that younger patient. It may or may not, but we need to repeat that Pap smear. Minimal changes are not likely to progress, and they may clear on their own. For an older patient, and if they continue on with abnormal PAPs, or if they have an HSIL, then it can progress. The HSIL is the threshold for treatment because it's a precursor to cancer. It goes without saying that you need to verify the identity of your patient and document that according to the HIPAA guidelines. But I wanted to give you an example of a way that you would document this in your CHR. The patient, who is a 32-year-old, was reached today by phone and give the phone number, and she was counseled regarding her abnormal Pap smear, which was ASCUS negative. She was recommended to have a repeat Pap smear every 3 years because of the lifelong risk of possible progression to a precancerous lesion. The patient was further counseled that an annual physical examination was recommended because we address other health concerns when she comes in for her annual exam. Her next Pap smear is due in 2020. The patient verbalized her understanding and her questions are answered. We want to remind our patient, if it's going to be 3 years before we repeat that PAP, that we do look at other issues or talk with her about other issues when she comes in. We're looking at health and wellness. We want to update their vaccinations at their annual visit, and certainly we want to provide them with their contraception needs. So the definition of escalating attempts is the progressive steps of trying to contact the patient that have an increasing likelihood of success. This means that we're going through escalating steps, such as the phone call initially, the first-class letter, and then progress on to the certified letter. We really have had, as I said before in the beginning, a serious issue with follow-up, and we need to close the loops. So one thing I want to make mention of is when a report comes in, the nurse needs to read it, the nurse practitioner needs to read it from beginning to end in its entirety. It's very important. You want to document clearly all counseling attempts at notification, utilizing the escalating attempts, and then stop. We can't continue on after a period. There's no consult needed to ask what to do. If you followed the escalating attempts, you need to just stop. It's not cost effective to continue on and on and on, and we're really trying to streamline the follow-up process. However, I will say when the patient comes into the clinic for any reason that it's an opportune time to discuss with them their abnormal findings, whether it be PAP or mammogram. So you need to be able to flip over to that PAP follow-up note or the mammogram follow-up note every patient visit so that you can talk with the patient or guide them again about their follow-up steps. One thing I did want to give you is maybe a helpful hint that I've used in the past myself. If you get a phone number when the patient is in for their annual exam or for a visit, follow-up supply visit is to get the grandmother or aunt or somebody who's a little bit older. Those folks in their family are less likely to move, and you're more likely to be able to call them and leave a message for your patient to contact you. Okay, if a patient does not respond to documented escalating attempts to the additional diagnostic procedure or the recommended management, then we consider them to be lost to follow-up if we can't contact them. Also, the patient may refuse the follow-up. So if we recommend to them that they go for a colposcopy, they may say, well, I just don't want to do that. We kind of need to know the reason for that, whether it be financial, and again, we would need to discuss that with her, or if there's some other reason. The patient may be scared about what we might find out, but we really do need to find out the reason that the patient refuses. The follow-up would then be considered to be complete or close to follow-up. And how we would document that is to make sure that the CHR1 is flagged in red. Our documentation would include that the chart is to remain open but closed to abnormal pap or abnormal breast follow-up at this time. But any time the patient calls the clinic or returns to the clinic for any reason, we're going to repeat our counseling and try to reappoint them if possible. So when we do come in contact with that patient, we're going to offer to reappoint them and go back through the recommended plan of care and the consequences of not following up. It goes without saying that we're going to document the risk and we're going to counsel them every clinic visit. But I do want to say that any person who's been previously lost to follow-up attempts should not be denied any future ADPH services. When they come in at the next visit, they can sign the declination form. But even if that patient signs that declination form, at the next visit, we're going to discuss the same issue and we're going to document our counseling. We offer the services and the referrals that they need. I do want to make mention that their contraceptive method is independent of their follow-up compliance. So if the patient needs a method and they're able to get it, then we need to be able to provide that for them. As I move forward, I want to talk about a case study. We had a patient who had a history of an L-seal at age 21. She came back for a repeat pap smear at age 23, and it was ascus. She had another repeat pap at age 24 that showed she had an ascus and she needs a colpo. What was documented in the chart was that she was counseled in July 2016. She did not go for her colpo appointment, and so the health department received a letter from UAB saying that the patient missed her appointment. There was no documentation in the patient's progress notes. The next documentation was in December of 2016, and it documented that the patient was non-compliant with their follow-up, and they were closed to follow-up. The problem with this particular case study is that there's a large gap in the progress notes. There's a lack of documentation. Remember that this is a medico-legal issue. This is not acceptable to go for months and months without documenting any kind of communication or missed appointments with this patient. Any missed appointments should have follow-up within 2 weeks. You should initiate that follow-up process. Then you want to have that phone call, the first-class letter. If no response, you're going to continue on with a certified letter. This particular patient had persistent disease. She needed a colposcopy, and she was closed to follow-up due to noncompliance with improper documentation. Nobody ever even tried to find out or document why she didn't keep her colpo appointment. So it's very important for us to try to figure out what's going on with our patient and try to follow up with them. I want to briefly go through some major principles of documentation. You've probably heard these before. All efforts should be done. All efforts that you have tried to reach the patient should be documented, and all the pathways to the patient should be exhausted in your attempts following the escalating attempts. But we want to talk about the accuracy of documentation. When we talk about accuracy, if we have sent the patient for a right breast ultrasound and we receive a left ultrasound report, then something's amiss with that document, and we need to call and verify what was done. So we need to make sure that what's documented and that our reports are all accurate, and we have the right document for the right patient. The documents need to be comprehensive, so as we document, we want to put the relevant facts and what's to be done for our patient. Things need to be legible. If you write in a sloppy manner, if you don't document in a timely way, this shows that we're giving inadequate care, that we can have misinterpretations about what we're doing. I also want to make mention that we should not use unapproved abbreviations, and that right now we are currently working on a tool that will provide approved abbreviations. The objectivity, we need to be impartial with our patients. There is a difference between a patient refusing their follow-up and declining. They may decline because they can't afford the services. We need to articulate this information in the chart, and we should not be biased to the patient. We want to continue to offer them our services, and definitely we want to make sure that they continue to receive their birth control method. Our documentation should be timely. If an HSIL comes in or a highly abnormal comes in, we need to take care of it that day, and our documentation should reflect that. We should not write in the margins that looks like information was added after the fact. Corrections need to have a single line drawn through it and date it and sign it, an initial. Don't leave blank lines. We frequently see this when we do audits, is that there are many blank lines on the progress notes, and we don't need to have that because things could be added later. So what I want to say about this slide is if a patient we need to obtain all previous colposcopy pap smears, abnormal pap smears, because that helps us to move forward and manage our patients, and especially if they're at high risk. So if the patient tells you that they had a pap 5 months ago, we go ahead and try to obtain that report. But in the meantime, if that patient is in for their annual exam, nurse practitioners go ahead and do your pap smear that day. You can hold that pap smear for 21 days while you're trying to receive that report, and then you can chunk it if it does come in and she has had a pap smear. But if your report comes in and that pap was 2 years ago, you have that pap, you can go ahead and send it, and you don't have to try to get that patient back in. The patient may not come back, so we have that pap on hand and can go ahead and send it. I do want to let you know that if the patient decides that they want to make their own appointment for herself with her provider of choice for that abnormal pap smear or for any kind of abnormal, the health department is still required to follow up to ascertain that that appointment was made and kept. And so a phone call needs to be made to the patient or to the provider to see if the patient came in, and if not, we want to continue on with the first class letter. For a non-compliant patient previously given a referral for management of, say, a colposcopy, we want to, and they're in for their annual exam, the nurse practitioner needs to document why she may or may not have omitted that pap at her annual exam. If the patient is in a follow-up mode, you want to look at the CHR and know what the recommendations are, and this should be listed on that pap follow-up note. If the patient returns for a supply visit or a DCS, we want to offer to reappoint if they've missed their appointments previously. We want to document our counseling and our efforts. This patient still may remain high risk until her colposcopy or follow-up is complete. If for some reason the patient does not complete her post-colposcopy management, a consult may be needed. So if the patient has gone for her colposcopy and she receives back current information that she needs say she had a positive ECC or positive margins, UAB or the other MDs may require that she have this 4 to 6 month follow-up with an endocervical curettage. So if the patient is past that 6 month window and they've missed their follow-up appointment, a consult may be needed. There is a technique utilizing the cider brush in a really vigorous manner that is considered to be highly effective, almost like the endocervical curettage. And so if that patient has missed that follow-up visit that required that PAP and endocervical curettage, the nurse practitioner needs to consult with a collaborating physician so that she can discuss this technique with you. And remember, for all discrepant results with PAP and colpo, the nurse practitioner would need to consult with her collaborating physician. As I've already mentioned, we do follow UAB guidelines, and these are national guidelines. I want to talk for just a minute about another case study. This is a 47-year-old who had an L-seal with a positive HPV. She had a colpo at UAB, which showed SIN3 and was recommended to have a LEAP. The LEAP was done, and it was a SIN3, and it extended to the endocervical glands. She had positive margins. So UAB recommended a PAP and ECC in 6 months. However, in the CHR, there was no documentation about this in the CHR. My main point in presenting this patient is that there was no notification of the patient. We need to document when we get the reports the follow-up management plan. UAB normally sends a follow-up recommendation and a date for return for the procedure to the referring health department. And it's our responsibility as in the health department to notify the patient of the abnormal results and the follow-up appointment and recommendations. And this should begin within 2 weeks after receipt of that information from UAB. I will point out that for some of these patients that are high risk, please again look at your ABCCP monthly sheet that comes out, or talk with your ABC coordinator so that if there's a possibility that ABC may be able to help financially with this patient, we want to brainstorm with her about payment options that she might not be aware of. So I want to talk for just a minute about another case. This was a 22-year-old who had a history of a colpo at UAB. It was SIN1. So she came back at age 25 and she had a repeat PAP that was an HSIL. It was SIN2 or 3, and she at that time had a colpo and cryo. At age 27, she had a repeat PAP that showed a high grade with positive HPV, and she changed. She went for a colpo at a private physician, and he did not obtain a biopsy but recommended a LEAP. The LEAP was done with a path report of SIN3 with the margins negative. The physician recommended follow-up co-test in 2018 and 2019. My main point in presenting this patient is, when do we notify her about the follow-up recommendations? And that needs to start immediately, within a 2-week period of time. Because this young patient may move, she may change her phone number. If we wait until it's right before time for her next co-test, we might not be able to get in touch with her. So she's a high-risk patient, and we need to notify her immediately of her results and what the management plan is. I'm going to switch gears here as we move from Pap follow-up to breast follow-up. This is the new breast follow-up note that should be placed immediately behind the breast tab. This is for continuity of care for your patient for follow-up. There will be no further documentation regarding abnormal breast follow-up done on the current progress notes that we know is the CHR-10. This note needs to be kept up to date, and the next follow-up appointment should be documented so that at a glance, the nurse or the nurse practitioner can flip over and know what to advise the patient about her follow-up. We're still going to keep the tickler system just like we did with the abnormal Pap. You're going to keep a tickler card on this patient because remember, when that patient leaves you, that chart is going to go too, and so we need to be able to track these patients. This is a list of the information that needs to be sent to the collaborating physician when your information is sent to the central office. I do want to say that if you send a consult on these patients for anything else, you need to note that this patient might be in breast follow-up so that your consulting physician would know that information. For patients who have a BI-RADS 0 and they have a negative clinical breast exam, there's no need to send any follow-up information to the central office if the other additional studies are BI-RADS 1 or 2. However, if you do have a positive clinical breast exam, you need to send all of the information, both the first BI-RADS 0, the follow-up studies, and all this information to the central office. And then after review from the central office, the mammogram follow-up information will be returned to the county, and it will be recommendations will be made, and that should go behind your breast follow-up form. Remember that your progress note, this progress note, your MAM follow-up note needs to be updated, as well as your tickler system. I do want to say that if your patient had a positive clinical breast exam, the patient requires that surgical consult regardless of what the mammogram or the ultrasound report show. Breast follow-up should be done and completed within 30 to 60 days. So we're going to talk about another case study. This was a 45-year-old with a palpable breast lump. She had a diagnostic mammogram that was ordered by the nurse practitioner. However, the patient missed her appointment. So my question is, what's the next follow-up step for this patient? Of course, she needs a phone call, and this needs to be documented. And if the patient is not able to be reached by the phone attempt, then we need to do the escalating attempts using the first-class letter and moving on to a certified letter. As far as some of your escalating attempts, I do want to make mention that you do not need to send a consult. As your escalating attempts moves on, then you need to have your advanced clinician review this and determine what steps need to be done as far as continuing her escalating attempts. But a consult is not warranted in this case. So what to go further with this 45-year-old with a breast mass? Medico-legally, it's not acceptable to have large gaps in our documentation. What I want to say about this patient is in about 4 months, she showed up at the facility to have her mammogram and ultrasound. And so she had this done, and it turned out to be a BI-RADS 4, where a biopsy was recommended. So again, we need to get in touch with the patient, let them know what needs to be done, and get her scheduled with the surgeon if it hasn't already been done. So this patient would need a path report if a biopsy is done and a follow-up plan of treatment. So the final step to this is the patient had an excisional biopsy and it showed adenocarcinoma, and the surgeon referred her to the oncologist for a plan of care. So is our follow-up complete? My main point in providing this case study is that we need to follow this patient through to completion. Sometimes the surgeon's report is not clear, and so the specifics about the oncologist's plan of care is always good to have. There may be variances in this plan of care with every individual that we see or that we refer. So once the patient is diagnosed and we know that she's under care, that's the most important information that we need. But the bottom line is that you will get a directive back from the central office or one of the collaborating physicians about this patient with a positive breast diagnosis about whether or not to get that oncologist's plan of care. Again, I want to say that we presented this because of QA and problems that we found, and we wanted to impart these issues to you, give you updates about what the follow-up protocol and the changes that we have. We wanted to make sure that the process was clear and that anybody could pick up and follow if for some reason the follow-up nurse, the designated follow-up nurse, was not there. It's very hard to make new changes about many things, and we wanted to be positive about these changes. We as a group want to help you. We want to work as a team. We want to work together to move forward and provide good patient care for the people that come in to see us. We thank you for all that you do. We know that you work hard, and we appreciate everything you do. Please call us if you have any questions. Thank you.
Excuse me. We do have some online sent questions. Thank you both very much. That was wonderful. You can continue to call if you would like to, but in lieu of time, we're going to go ahead and take the questions that have been sent to us.
The first question that we have, excuse me, is when do you fill out the initial deferred physical? So when the patient comes in for their deferred physical and they're an initial patient, which history do you fill out? And that history that would be filled out on the initial patient is the 3-page annual self-history form, so that you do know what birth control to dispense, so that we do have their medical history, and then the updated history would be filled out if they come back for their physical exam within at the 6-month period. So the initial deferred, they would get the 3-page annual patient history form. The other part to that question is how do we address the symptoms listed, and those would be determined by what the symptoms that they marked. It would be the nurse practitioner or the registered nurse would delve into that information. If they're having pain or burning, that may be something we address. Or if they have chest pain, that could be, it would have to be a referral. So, you would just get more information and then you would go from there.
If I can just expand on that question just a little bit more, that answer from Luana. Keep in mind that the patient self-history is a primer, if you will, and sort of will prompt you to ask the patient, additional questions. So I think that's the way that ought to be viewed. So if anything is checked off under review of systems, it should prompt the clinicians, whether it's a registered nurse or the nurse practitioner, to delve further into those issues with the patient. And it may or may not need, a referral or require a referral. So I think that's how that ought to be handled.
We're going to take a call. We have a phone call from Baldwin County. Caller, you're on.
Hey, it's Teresa.
Hey, Teresa.
I got a quick question for Deborah Davis. She said when she was just, can you hear me?
Yes.
Oh, okay. when Deborah was talking about Pap smear follow-up, she said something about leaving a message with a family member. Does that violate HIPAA?
Okay. When you call, you can always just leave your name and a phone number. You don't leave information about the patient. You call and you may say, my name is Deborah Davis and I'd like to leave my phone number, BR549, and please have Jane Doe call me.
So don't say you're calling from the health department. Just
No, you just want to get information for that patient to call you, but you don't violate HIPAA in any way by leaving your name and a phone number.
okay, thank you. My next question is for Krista.
Yes.
On that breastfeeding on page 5, where it's talking about risk factors, are we going to give combined hormonal contraception to breastfeeding mothers now? Or am I reading that wrong?
So you're on page 5, and so
under breastfeeding.
Mm-hmm. And so you have, for every combined method until you get to 42 days postpartum, if that patient, there are other birth control methods that are less risky, and we have less risk that a clot could occur. So if a patient came in, I know we've always said we don't want to give a combined method to a breastfeeding patient because it may decrease their milk supply. That could always be a phone consult if you had questions and the patient wanted a combined method. But I think that MEC listed everything as a 3 or a 2 for a combined method with a phone consult. So we added that information. That's if she didn't have any other risks, if she was obese or had a high blood pressure during her pregnancy or a smoker. That changed everything. So we wouldn't necessarily give one. We just added this part because MEC included it. And then we would always consult Dr. Thomas just in case if we were going to dispense a birth control method before the 6-week time for breastfeeding patients. Well, that would be more of a combined issue with the breastfeeding patients postpartum.
Teresa, I just wanted to go back to your previous question. Dr. Maxwell is here with us, and we appreciate her being here today. She helped us develop the PAP and the breast follow-up forms. As far as the contact information goes, we also have a block there. That's sort of a trigger so that you will think about asking them at that time their most recent contact number, because as you know, that can be difficult at times. So that's just a point I wanted to reiterate with your contact information to help us contact them.
And you really, I want to tack onto that, is you're asking their permission, can I leave a message with them
yes,
to
absolutely.
call? And
absolutely. Does that help?
Oh, are you talking to me?
I am.
Oh, yes.
Good. Good.
Sorry.
Good. And I know you've got another question, so go ahead.
Okay, I'm still with Krista on the breastfeeding. So if they're greater than 6 weeks postpartum, are we going to give them combined methods if they're breastfeeding and they have no other risk factors?
If they're greater than, like, over 42 days postpartum, it does list it as a 2, so we wouldn't require a phone consult. So you could dispense after the 6 months period postpartum a combined method. So if a patient came to us less than 6 months, usually patients come to us, hopefully they've already had their postpartum exam, they come to us with their form, and we kind of evaluate them. Usually they're not coming in less than 6 weeks, but if they do, and they are not going to follow up with their provider, and we know that we still don't want to not give them a birth control method, that might be a consult if it's less than 6 weeks. But a combined method you'd be worried that the combined method would cause a blood clot in that patient.
So in general, you would not, the patient has to be, if breastfeeding is an issue, the patient has to be established, has an established routine for breastfeeding before dispensing a combined method, because as Krista mentioned earlier, a combined method could interfere, if you will, the quality of with the quality of breast milk that is being produced. So if you don't want to dispense before, certainly not if a pattern of breastfeeding is not well established. I don't. Does that help or answer your question?
Yes.
Okay.
Yes. I got one more question. I'm sorry.
Go ahead.
I'm going on to hypertension now.
Okay.
On page 13, this is for Krista. On page 13, under hypertension, it's got a little check by hypertension, and you look at comment, and it says see hypertension and abnormal findings. Are they talking about folks with undiagnosed hypertension?
We have that algorithm in abnormal findings that you could still refer to. That still gives guidance on what birth control methods, as far as a progestin only. So you would still, when we did the abnormal findings, so a lot of that information is still important for hypertension and anemia. Those are just two off the top of my head. So you would just refer, if you did have an undiagnosed hypertension, you could use abnormal findings to kind of help you with that process. Does that make sense?
Okay, so if they're undiagnosed, refer to abnormal findings. And if they're diagnosed, we can use this algorithm here on page 13.
Yes, but if you still had a patient that came in with a blood pressure of 160 over 100 on multiple occasions or multiple rechecks, you still need to refer her, but you would still, it helps kind of guide us with what we've got on page 13 on how we would dispense the method now. So we would still refer her, and she still needs to be diagnosed, but she still may have these elevated blood pressure readings even though she's undiagnosed. Does that make sense?
Okay, thank you. Yes, thank you.
Okay, thank you.
Thank you.
All right, bye-bye.
So we have a few more. If a patient wants a method and it requires a consult, such as a 2 with the asterisk, can we go ahead and give a month's supply of the method and do a consult using email? Or are we to make a phone call and get an answer while the patient is waiting before we give the method? I guess if the nurse is using the email, they're saying, do we go ahead and call just to make sure?
It's according to what your consult column says. I would think would be the first place to look, as according to whether it's a phone consult or a written consult. If it's a phone consult, then obviously it's a higher degree of need to talk with your collaborating physician. Does that help? Oh, this isn't a caller. I'm sorry. If that doesn't answer your question, we'll have some more comments on that, and just email us if that doesn't answer your question.
Yeah. Because with the new nurse consultation piece, we stated that they needed to call the collaborating physician.
Yes.
But some of the situations are, we would not be calling the collaborating physician. We would do it in a written consult. So when a nurse is consulting the collaborating physician, do we want them to all be phone calls followed by an email, or do we want just the email part?
Phone calls.
Phone calls, okay.
Yeah.
And the phone call with the collaborating physician will give you a chance to talk through the situation. We always learn a lot through our consultations with Dr. Thomas, and we don't want to say you did. That patient was there for a depot, and you decided, well, I'm going to give her a 1 month supply of hops. Well, you're changing her method to a less effective method. It also is putting her in a more risk for pregnancy because there's another barrier she's going to have to come back. So in that instance, a phone call, give her whatever method, and then follow up with an email. Hopefully that'll answer that question.
Okay. The other thing, we did have someone let us know that the immunization up-to-date piece was left off of the annual patient self-history form, although it is on the updated history form, and that is a Title 10 requirement. So we do need to address that with their annual and initial exam. That can be done, on the last page where you can expound on that and just make a little note that you did discuss that and that you did talk about that. The GYN history does not ask about a prior colposcopy, but it does ask about abnormal pap smears, and we did say any question with a yes answer needs to be expounded on.
And if I can just add to that, keep in mind again, in trying to make this, I guess, user-friendly and to diminish the amount of questions that are asked, some things had to be eliminated. And so again, thinking in the line of this being a primer and a prompter, if a patient has had an abnormal pap, the next question should be, have you ever had colposcopy? So it's a prompter for you to ask those questions, and you, the clinician, the registered nurse, or the nurse practitioner can expand further in your assessment and plan comments page.
Thank you. Another question we have is if a patient has an abnormal pap smear and goes to another provider for their colpo, and they say that they're just going to stay with their physician, they're no longer going to come back to the health department for pap follow-up, what do we do? Do we close or do we continue to follow? And I guess that would be if they continue to come to the health department for their birth control, we would still want to make sure that we get those records and make sure that things are being done that are.
So what I would say is if the patient says that they are going to follow up with the referral doctor to obtain subsequent PAPs, then that has to be clearly documented that conversation was had with the patient, and she will take on the responsibility or the onus of following up with the referring physician. I think if it's in the mode where we're doing co-testing or PAPs, those can be requested from the doc to be a part of our chart, from the referral physician to be a part of our charts. But again, if she's coming back to the health department just for birth control, I think that's how that would be handled. I think the records would be obtained on an annual basis, or every 3 years, or however frequently the patient is having PAPs done elsewhere. But in general, if the patient is seeking that care elsewhere, I think the best tack is to document that conversation carefully.
Another question we have is if a first-class letter is sent, does a phone call still need to take place as well? Currently, our protocol says on page 11 and 12 under escalating attempts, it doesn't require both. For example, if they missed an appointment for an abnormal finding that warrants a repeat lab, they require a first-class letter or a phone call. And I think,
yeah, I'll try to respond to this question. We've talked about this a good bit as we've looked at protocol and tweaking it. And if you look at page 11 where it says when we refer that requires up to a certified letter, if you'll sort of zone in on that rule and you think about any time we refer somebody outside the health department, that's going to require up to a certified letter. If you do something more in-house that's for like a missed appointment, and you're reminding them they missed their annual exam and they're coming back, and you need to remind them, that can just be a one-time letter. The escalating attempts is when we refer outside the health department and we're trying to make sure that the patient is getting the care that they need and that we're reaching them. I hope that helps. If not, send us an email for further clarification. Yeah, and Dr. Maxwell wants to add to that.
So with the documentation for follow-up, a lot of times we'll get information that just says a letter was sent. We don't know if that was a certified letter or if that was a first-class letter. The other thing that I would caution you about, until we move to a more standardized approach, I've seen several different letter types. Some letters are a quick handwritten note. Some letters, they don't have any letterhead. If we're contacting a patient to say, please contact us about your missed appointment, you don't have to go into details, but we need to be clear that this letter was a contact to notify them of a missed appointment. And so when you document, we need to know if it was their first-class letter or if it was the certified letter. And to reiterate what Beth said earlier, you don't have to send in a consult at each step of the follow-up process. You can keep that file open until you've exhausted your attempts, and then send the consult in and we can close it at that point.
Thank you very much, Dr. Maxwell. I think we have another question.
This pertains to, it looks like there's an area that sends their patient for the COPO and they're having a hard time getting the results unless the patient goes back. And so what they wanted to know what to do in that situation when they were having a difficult time getting the results. And I guess that would be just handled on a case-by-case basis, depending on what we referred them for and why we couldn't get the results. And if we never could get the results, maybe we should contact Dr. Thomas. And
So I'd like to know about the referral providers that are not providing us with the pathology reports, because we are referring the patients to these providers, and in some instances, if they are breast and cervical, Alabama breast and cervical providers, we've got a contractual relationship, ADPH that is, with these providers that obligate them to provide us with these pathology reports and what have you. So, and I know Dr. Maxwell is in the real world, and she tells me that this is kind of a common occurrence with not getting reports from referral providers. So I'm going to ask her to just comment on that. But to answer your question more specifically, I'd like to know if there of these providers who are not giving us the information that we need.
So when this happens, you have a couple of options. Sometimes I will batch request. If I've sent several patients, haven't gotten reports, sometimes we can say, look, we've sent several patients, we have no follow-up, please send results. Sometimes that will work. Sometimes it's a phone call to the provider's medical assistant or nurse, and then sometimes it's a call to the office manager. If it continues to be a problem, then we may have to look at, do we need to end that relationship with that provider. But usually if you can get someone on the phone and kind of figure out, hey, what's the problem? It could be that the fax number that we're using goes into a fax queue, and so they don't see those on they have to look at those periodically. But usually a phone call to speak with someone, there is something identified that there was a glitch in the process. But if it continues to be an issue, and then we may need to look at, do we need to change those relationships? But again, phone calls usually will get you get something accomplished, and usually there's a problem. Either it's the wrong fax number or it's not being sent to the attention of the right person, so it gets shuffled around. So usually a phone call can identify what the problem is and rectify it.
Thank you so much, Dr. Maxwell. We had a phone call from Marshall County. If you're still on.
Yes, I am.
Great. We're going to take your phone call.
I have a question on sending the first class, or sending a letter in general. I know at one point we had been told that if you send a letter, it had to be the letter from the protocol book. It couldn't be like a handwritten letter or a typed letter that says you missed your appointment. It had to be the letter out of the protocol. Is that true, or can we send something that just says you missed your appointment?
The letter that's in protocol is preferred, like Dr. Maxwell was talking about. We can look at that a little more, but that's the standard, form letter that represents Alabama Department of Public Health.
So we should send that and not type our own letter?
Yes.
Okay.
Yes.
Thank you.
Yes, thank you. Thank you very much for calling in. We appreciate all the calls. We haven't gotten to every email question, but we will. And so at this time, I'm just going to close and say this concludes today's program. I want to remind everyone that CE credit is available for Alabama Department of Public Health employees and it will expire on September the 1st, 2017. Thank you for all our presenters and our physicians. We appreciate all that you do every day and for sharing their knowledge with us and helping us to learn and grow. I hope you have a great day and a wonderful afternoon, and we appreciate everything you do. Be in touch. Thanks again. Bye-bye.